This video is the first in a series covering immunologic disease states, also known as autoimmune diseases. This first video will focus on the condition known as systemic lupus erythematosus, abbreviated SLE, or sometimes just called lupus for short. Before I start talking about lupus specifically, it's worth reviewing hypersensitivity reactions in general as they relate to autoimmune conditions. Our immune system is an integral part of our health and function, and as long as immune responses are maintained within a normal range, we will typically stay healthy and free from disease. However, if our immune function is suboptimal because of immune suppression, this can lead to increased risk of infection and cancer, and possible morbidity and mortality. In addition, on the reverse side, when the immune system is enhanced, you can have hypersensitivity and autoimmunity, which can also lead to morbidity and mortality. In this series of lessons, we will talk about this immune enhancement, which results in hypersensitivity reactions. The hypersensitivity reactions we will talk about are all due to T cell overactivation. This is depicted in the scheme on the right, in which some antigen, which is something that stimulates the immune system, causes dendritic cells to activate certain T cell subtypes. Depending on the T cell subtype and the type of immunoglobulin or Ig that is released and leading to an immune reaction, this results in 4 different types of hypersensitivity reactions, 1 through 4. This hopefully should be a review, but I will briefly describe each of the 4 hypersensitivity reactions now. Throughout the next series of lessons, we will go into more detail on types 2, 3, and 4. A type 1 hypersensitivity reaction is mediated by IgE immunoglobulin, and this is what we typically associate with allergic rhinitis and other common allergies. In this case, an antigen stimulates mast cells to release their contents, including inflammatory mediators. In a type 2 hypersensitivity reaction, also known as tissue-specific hypersensitivity, overactive Th2 T cells release IgM and IgG immunoglobulin antibodies that target specific proteins found in the body. In this case, the proteins are typically cell surface proteins that have stimulated the immune system to produce a response. Once the IgM and IgG antibodies target cell surface proteins, this can result in inflammation and cell death. A type 3 hypersensitivity reaction is also called immune complex mediated. This also involves IgM and IgG antibodies, but in this case, the antibodies form complexes with the antigen that then deposit in soft tissues like the joints. This also results in an inflammatory reaction that can damage the soft tissue where immune complexes have deposited. Types 1 through 3 are all mediated by Th2 T cell overactivation. In contrast, when the Th1 subtype of T cells is overactivated, this results in a type 4 hypersensitivity reaction, also known as cell-mediated. This is when these activated T cells directly cause cellular damage. In the case of lupus, this is a systemic autoimmune disease that can affect virtually any organ system in the body. In fact, it is sometimes called the great mimicker because it can look like a lot of other disease states. It is characterized by multiple relapses and remissions over decades. Because lupus can affect virtually any organ system in the body, depending how it presents in an individual patient, no 2 cases of lupus are alike. Currently, lupus affects about 500,000 people in the US and is significantly more common in women, as demonstrated by this figure. The predominance in women is approximately 9-1. In addition, lupus is much more common in women of African American descent, occurring in about 1 in every 250 African American women. In contrast, lupus occurs in about 1 out of every 1,000 Caucasian women. Lupus is probably the most common, but also the most complex and serious of all the autoimmune disorders we will discuss. There's a wide range of possible onset of the disease, and it can occur anywhere between the ages of 15 and 50 years old. There are several factors that contribute to the development of lupus that include both genetic, endogenous, and environmental factors. In terms of genetics, it is known that lupus runs in families, and specifically, if a first-degree relative has lupus, you have a 20-fold increased chance of developing lupus yourself. The genetic susceptibility is multifactorial, and at least 20 different genetic loci have been identified, as well as epigenetic changes that contribute to the development of lupus. In terms of the relapsing remitting pattern, there are specific predisposing factors or triggers that are known to lead to a relapse of the disease. This includes a history of smoking, exposure to ultraviolet light, and previous exposure to Epstein-Barr virus, among others. Given the predominance in women, it is thought that an imbalance in sex hormone levels and or the presence of a second X chromosome could somehow contribute to the development of this disease state. However, the specific mechanism by which these are involved is not yet known. There are some pharmacologic agents that can cause a drug-induced lupus-like condition. The two primary agents that are able to do this are hydralazine and procainamide, and therefore a medication history is very important in a patient suspected of lupus. The pathophysiology of lupus is thought to be due to a phenomenon known as loss of immune self-tolerance. Normally, our immune system becomes tolerant to the body's own cells and proteins over time so that it does not constantly attack our own body. However, in individuals with lupus, this ability to produce self-tolerance is diminished or lost, and therefore the immune system begins to mount reactions to the body itself. This is thought to be due to an increase in the activity of the Th2 T cell subtype or reduced activity of the regulatory T cell subtype. Lupus is also characterized by the production of antibodies by B cells against various parts of native tissue. This B cell production of antibodies against native tissue is known as autoantibody production. In lupus, there are very specific categories of autoantibodies that are generated. One group of autoantibodies are created against surface proteins on blood cells, like white blood cells, red blood cells, and platelets. This is considered a type 2 hypersensitivity reaction because cell surface proteins are bound to antibodies that then target those cells for destruction. In lupus, the type 2 hypersensitivity reaction results in antibodies being generated against blood cell surface proteins. This leads to a reduction in blood counts and can be evidenced in labs by anemia, leukopenia, and/or thrombocytopenia. The other primary group of autoantibodies are against DNA, RNA, and other nuclear or cytoplasmic proteins. This is a type 3 hypersensitivity reaction because it is immune complex mediated. Specifically, DNA, RNA, and other proteins serve as antigens against which antibodies are generated. These antigen-antibody complexes become trapped inside tissues, and this causes an intense inflammatory response in an attempt to destroy the immune complexes. In this portion of the disease pathophysiology, inflammation is the ultimate cause of tissue injury. The graphic here depicts a type 2 hypersensitivity reaction, which is common against blood cell surface proteins in lupus. You can imagine that this is showing a blood cell, like a red blood cell, which normally has proteins attached to its cell surface. For some reason, these surface proteins trigger an immune response that results in antibodies, or IgG, directed against those surface proteins. Once those surface proteins are decorated or bound by antibodies, they are then targeted for degradation by either complement independent or complement dependent cytolysis. In complement independent cytolysis, you have cytotoxic cells that bind to the blood cells and cause their destruction. In complement dependent cytolysis, you have the activation of the complement cascade by the autoantibodies that results in a destruction of the blood cells as well. The other aspect of lupus pathophysiology is a type 3 hypersensitivity reaction against DNA, RNA, and other intracellular proteins. In this case, IgG or autoantibodies are produced against these protein or DNA antigens. The antigen and the antibody bind together to form a complex that then becomes deposited in soft tissues throughout the body, such as the joints. This stimulates an immune reaction that recruits neutrophils, macrophage, and other immune components like complement. This results in the destruction of cells within the soft tissue, as well as additional inflammation and tissue damage. Based on the type 2 and type 3 hypersensitivity reactions occurring in individuals with lupus, the resulting effects are very unique in each patient. However, there are some groups of clinical symptoms that we can identify. In general, lupus develops very slowly and is characterized by relapses and remissions. The vast majority of individuals with lupus will experience arthritis, vasculitis and rash, renal or kidney disease, hematologic abnormalities, including anemia, leukopenia, or thrombocytopenia, and cardiovascular disease. In addition, patients with lupus will present with immunologic findings, which basically means the type of antibodies present in their blood. The first antibodies that can be observed are anti-nuclear antibodies, or ANA. About 95% of patients with lupus will demonstrate anti-nuclear antibodies, and this is not specific for lupus. It merely indicates some type of autoimmune disease. Anti-DNA antibodies are a bit more specific. About 60 to 70% of patients with lupus will exhibit anti-DNA antibodies. This is relatively specific for lupus because only about 0.5% of non-lupus individuals exhibit these kind of antibodies. Anti-Smith antibodies are another common immunologic finding, but these are only present in about 20% of patients with lupus. Two of the common clinical signs in individuals with lupus are specific types of rashes. The first is known as a malar rash or a butterfly rash, as evidenced by this image here, which appears over the nose and cheekbones in somewhat of a butterfly shape. The other common type of rash in individuals with lupus is a discoid rash, which is demonstrated in the other image shown here. There have been 17 common elements identified across individual patients with lupus. And for a diagnosis of SLE, there needs to be the presence of at least 4 of the common elements, including one clinical sign, like the malar rash, for example, and one immunologic sign, such as anti-DNA antibodies. Other assessment techniques for lupus include joint X-ray, which can provide information about the type of arthritis that patients are experiencing, and also an elevation of the erythrocyte sedimentation rate, or ESR, is common in individuals with lupus. An elevated ESR indicates ongoing inflammation or autoimmunity and is also not specific for lupus. In terms of prognosis for lupus, there are some complications that can occur either early or late in the disease process. Early complications include infection, which is due to reductions in white blood cell counts, and renal failure. Later complications are heart attack and stroke, which are both due to the cardiovascular dysfunction, as well as cancer and bone disease. In terms of monitoring, some of the important ways to monitor patients are their response to symptomatic therapy. And fortunately, the 10-year survival for lupus well exceeds 90%.